Hi, I'm Dr. Mike Milligan. I'm here with Dr. Christian Guilleminault, MD, the founding father of sleep medicine. He opened the first sleep lab back in Paris many years ago.
In 1970.
1970. The volume of research papers that he has is world-renowned. And he's now a professor of psychiatry and behavioral sciences at Stanford Center for Sleep Sciences and Medicine.
The Division of Sleep Medicine.
Division of Sleep Medicine. Well, Dr. Guilleminault, what is the prevalence of sleep disordered breathing?
We don't know exactly, but it's very high. If you include all the people who complain about their sleep, which is one measure, you will probably go to between 60 and 70% of the general population. Doesn't mean because you complain about your sleep that you have a sleep disorder. Very often in a current nomenclature, what they ask is that you complain about your sleep on a regular basis for at least the last 3 months.
Okay.
And that the complaint about sleep has an impact on your daytime well-being.
Okay. What are the problems with sleep disordered breathing? Why do we need to treat that?
Well, you know, sleep disorder breathing, basically you find a problem in the Bible. You find that people report about snoring for many years. Wife and girlfriend complain a lot about snoring, and the men are ejected from the bedroom and they don't like it. So the problem has been, what is sleep disorder breathing? Historically, the medical studies started in the 60s on a very big fat man called Pickwickian, and the first recording of abnormal breathing during sleep on this Pickwickian patient was done in Germany by someone called Gerardi in 1960 exactly.
Okay.
And for about 10 years, everybody focused on obesity and Pickwickian syndrome. And then progressively, and personally I was very much involved in that venture, it came out that people who were non-obese had also abnormal breathing. And one of the questions was, when does that begin? And what lead to this abnormal breathing?
Right.
So you have two very different problems. One is the obese person, and the obese person is going to put fat everywhere,
Right.
and men more in their neck initially and in their tongue,
Yeah.
which is a huge muscle. And if you put a lot of fat in your tongue, you are going to decrease the size of your airway.
Sure.
But you also put fat in your abdomen, and you are going to have a combined problem of not breathing well because of the fat in the abdomen, particularly during sleep, because you have a restrictive chest below disease,
Right.
and you are going to have a problem in the upper airway. So that's one type, and for many, many years, people have associated sleep disorder breathing with big fat men.
Right.
Actually, it's not.
It's many others.
Yes, and one of the big question has been, well, what lead to sleep disorder breathing? Is there something which appear in adult, or are there problems that you can recognize very early on?
Okay. So you can see it very early on, and some of the causes of sleep disordered breathing then would be?
Well, let's face it, when you sleep, your airway, which is surrounded by muscle,
Yes.
so it's a collapsible tube,
Uh-huh.
has greater risk to collapse because when you sleep, your muscle relax.
Right.
And the reflexes and the muscle tone is different during sleep compared to wake. So, and on the top of that, you don't sleep standing up, you sleep supine.
Sure.
So you have two factors which are going to play: the position and the fact that your control of your muscle are different during sleep, and the reflexes are different, and the muscle tone is different. So you are going to have risk factor which are going to be present actually very early in life. When in the 1990s there were large study looking at obstructive sleep apnea, which was a syndrome, and what came out was that family have a tendency to have several members with obstructive sleep apnea.
Was that be genetic, or would it be more environmental?
Well, initially, and Dr. Susan Redline was one of the people who did a lot of the genetic study, because if you have a familial tendency, you may suspect that there is a genetic problem. However, what came out from these studies is that yes, it runs in families, but there is not a single gene that can explain sleep disorder breathing. So the goal has been to try to understand what are the risk factors which exist very early on, which that can lead to abnormal breathing
And
during
what would
sleep.
that be?
Well, you don't have one issue. You have, of course, several. Yes, let's face it, you look like your parents and you look more like one side of the family. So there is something which is either environmental, which you live through, or some genetic factors, and probably you have a combination of both.
Okay.
So the quest has been to try to decipher what can lead to development of sleep disorder breathing. And we were very much helped by study done by orthodontists that were interested in understanding the development of not the airway, but the oral cavity.
This would be the rhesus monkey?
Yes.
Rhesus monkey study?
Yes, and
Tell us about that.
Arvold, Vargavit, Miller, and they were studies done in the monkeys, but they were also studies done in children, particularly in Sweden, but McNamara was in the US, and these people realized that there was looking at the study done by Moss about the growth of the face in children, that there were differences in growth of the orofacial structure during childhood. And first it was shown that you had a very fast growth up to 6 years of age. Then you have a latency period, and then the second growth during puberty.
Okay.
And the people doing research on monkeys at UCSF find out that if you impair nasal breathing by putting a small ligature on the nose of the newborn rhesus monkey, you have a lot of changes in the growth of the face. And they were interested in the teeth,
Right.
so they demonstrate that. And what they demonstrated was that nasal resistance, abnormal nasal resistance, led to change in firing of the muscle particularly the tongue and all the muscle in the upper airway. And this firing was abnormal, and this abnormal firing had an impact on the growth of the bone.
Right.
And there is always an interaction when you talk about growth between bone and muscle. And in human, there are growth centers which are located in the face, and two are very important. It's the intermaxillary growth center, which is called synchondrosis, and the alveolo-dental ligament.
Okay.
These places are active till about 15, a bit earlier, stop to work a bit earlier in girls than in boys, but around 15.
Okay.
And what came out is that the stimulation of this growth factor are very important for the further development of the face after birth.
Okay.
So,
what stimulates that? Those centers?
Well, there were different studies. The first study was to demonstrate that what was seen in a monkey was true in children, in human.
Okay.
So the first type of study was to say, well, if we looked at abnormal muscle tone due, for example, to genetic problem,
right.
And we have muscle dystrophy, etc., what happened? And the first thing was, well, you don't grow very well your facial structure, okay, and your upper airway. Then so that was the first demonstration. The second thing was, okay, let's take another model in human where we know that we have really abnormal muscle tone, and that was a premature infant.
Right.
And the premature infant, particularly younger than 36 weeks of gestational age, will have abnormal muscle tone, and they are going to have abnormal orofacial growth.
Okay.
So that was two demonstrations that there was some abnormal interaction very early on between muscle and bone, and you did not grow your face appropriately, and you developed sleep disorder breathing. Then the idea was, well, maybe these growth centers are involved, so let's look at abnormality of the growth center, and they are usually due to genetic abnormalities, and they are what are called the connective tissue disease, like Marfan or Ehlers-Danlos syndrome, where you have abnormal mutation, and you cannot make your intermaxillary region work properly, and you have, again, development of sleep disorder breathing. And then there was looking at the alveolo-dental region, which is another growth center, and you have, again, genetic disorder will lead to absence of teeth, which is called oligodontia.
Right.
And you find out that, again, you have an abnormal orofacial growth, and you have a narrow airway. So, so you see, there were a lot of demonstration that was important. So the next step was to say, okay, what in a normal child lead to the growth? And it's the interaction between the muscle and the bone, and through this specific region.
Okay.
And what stimulates very much that this region? Well, it seems that it's essentially the tongue muscle, which is huge. You have
very powerful.
Yes, the strongest muscle in our body.
Is that right?
Yes.
Wow.
And it's the largest muscle for the space.
As a dentist, I believe that the tongue muscle is the strongest muscle in the mouth because I'm always fighting it, trying to fix those teeth.
And it's true. So the next question was, okay, what from birth on can impact on the activity of this muscle?
Okay.
So one thing which is known but not very much looked at is a short lingual frenulum.
Right.
And it's under the tongue.
Right under there.
And it's, I always tell my patient, it's like a fibrous tissue, a bit like a ligament, which usually kind of is very much stretched at birth, or is not even clearly seen. But some people have it short and poorly placed.
Also called a tongue tie.
Yes.
Right.
And it was shown that...
I had mine resected.
Well, hopefully at birth.
And it wasn't at birth, and that's why I've got the high palate.
Yes, that's one of the things that people don't realize. They still clip it when they recognize it. You can clip it only at birth.
Yeah.
If you do it clipping only after birth, it's going to reconstitute itself, and you still are going to have a short frenulum for the rest of your life.
Right.
So you have to do other things.
And we see so many kids that did not have that done.
You are right. In a study that we did on sleep apneic children that came to the clinic, it was nearly, it was 48% of out of 150 who had still a short lingual frenulum. So it's something which is really missed.
With that short lingual frenulum, the tongue cannot get up to the palate.
Correct.
Where it's supposed to be and expand and form that palate.
Yes, and stimulate that intermaxillary growth factor. The thing is, we know for a long time that the children may have difficulty sucking, particularly breastfeeding, and some other cannot, they believe that they are guilty, but they cannot breastfeed feed because the child cannot because of that. Yeah, they may also have difficulty chewing, they may have difficulty swallowing, and they may have difficulty with speech. So it varies depending on the age, and nobody, you may have a child sent to speech therapy, but nobody looked at under the tongue. And nobody had looked at the relationship with sleep apnea. We did that fairly recently, but it's a big factor. So that's another issue. And there are other factors which are going to impact, and they are the function. What are the basic function for an infant very early on? Sucking. You need to feed independently what you use, if the breast or bottle. There is one thing which is well known. It's much harder to breastfeed than to bottle feed if you use a regular nipple. So, mothers know that very well, because a certain number of children, when the mother has to pump and give a bottle because they work, etc., the child after that doesn't want to take the breast anymore. Why should he work?
Hard to work.
Yes, but you see, the hard work means muscle tone, exercise.
It's just like nutrition. If the child is eating noodles all the time, they're not, when they're a little older, they're not functioning, and their oral muscles can't develop.
It's not only the noodles, but it's all these little jars where that they don't have to chew.
Right.
And there is no doubt that if you don't chew properly, 6 months, you should use carrots and apples, and because you have to chew, and you have to chew on the back, you are going to muscle and you are going to make your face grow.
Right.
So the growth of the face is very critical, and it's related to the function of sucking, swallowing, chewing, and also nasal breathing.
Talk about nasal breathing, please.
Well, people who are doing obstructive sleep apnea, pediatric obstructive sleep apnea research always mention you have to take out the tonsil and adenoid, right, because they are responsible for your obstructive sleep apnea. Yes and no, meaning they are responsible, and everybody thought that it was because they take a lot of space in your oral cavity, and but that's not sufficient. They also block your nasal breathing and lead to mouth breathing.
Right.
And for years there have been a lot of knowledge about the fact that mouth breathing means airway resistance. If you run, if you are an athlete, you train, you carry on breathing through your nose for a long time. If you don't train, you open your mouth very quickly.
Right.
Okay? So there is a relation between what you can do, the effort, and mouth breathing mean that you are not using at all the upper part of your airway.
Right.
When you don't use something, you have what is called a disuse, and you lose the function.
Right.
And in young children, that loss occurs fairly quickly. We have a lot of information which are picked up by senses. For example, if we breathe through our nose, there are at least 10 mechanoreceptors who tell us the speed of the flow, how is the temperature, are there turbulence, all these things, and all this information are sent to a big computer which is on our brainstem,
right,
and there are adjustment of the fibers of all the muscle of the upper airway. If there is no information, the computer doesn't receive any feedback.
Mouth, they don't get the feedback.
Exactly. So that's one of the big problems, and unfortunately, we do very often half of the job. For example, we understand that there are enlarged tonsil and adenoids. We don't look if these have been existing for some time. You know, the mean age of tonsillectomy in the US is 7.5 years of age.
Okay.
These tonsils may have been present since 2 years of age.
Sure.
So you have 5 years where the child has not used his nose,
right,
and also when there have been a blockade. So to take out the tonsil and adenoids mean good, but that's half of the problem, because we have need to learn how to breathe through the nose.
It's so important to breathe through the nose.
Absolutely. We are obligatory nose breather. And the end treatment of any sleep disorder breathing is nasal breathing.
The end treatment of any sleep disordered breathing is nasal breathing.
Correct. We even published that with my colleague Dr. Sullivan, Shannon Sullivan. It's absolutely necessary. If you don't obtain that during sleep, because you may do that during wake, but you have to check during sleep, you have not succeeded in treating your child.
Okay. So some things that we can do would be the tongue tie, to be sure they're nose breathing as opposed to mouth breathing.
Well, you have to do the reeducation, and
functional therapy.
Not only that, you see, the nose, you have to have sensory receptors activated. So there are a lot of different ways, and there are specialists who do that. You make irrigation of the nose and make
Really?
it go, yes, with, nollie pat and rinse and something like that. You also make the child press on one nostril, take a big breath, and the other side, that they learn. And also you re-educate the muscle as much. So the nasal re-education and the muscle tone re-education is very critical for any treatment at any age.
Now, muscle tone re-education, that would be your myofunctional therapy?
Yes, yes.
Can you tell me about that a little bit?
Yes. Well, I think that it was already in the 30s that someone gave the name myofunctional therapy. And so it's not new. In Europe, someone who was very much involved was orthodontist, stomatologist, which is medical school. His name was Delaire, and you have Mask of Delaire, orthodontists know these things. And he realized that there was a lot of mouth breathing, and he created the first organized center, a bit like surgeon in orthopedics know that you do surgery because you break your leg, you put a rod, you do anything on the knee, you are going to have to go and re-educate the muscle because they get atrophic. Well, the tongue is the largest muscle for the space. What do you do if you don't re-educate that muscle? We do it everywhere else. We don't think that the tongue is a muscle. So we have to re-educate all that region, and we do maneuver. And also we try to emphasize the normal function. For example, you are going to teach the child to chew on the back and on both molar, both sides. Yeah, you are going to teach the side to swallow the proper way. You are going to be sure that speech is correct. And you find out that a certain number of children don't know even where their tongue is. We call that apraxia of the tongue. One very simple test is to what you call make a cigar tongue. Curl and pull out the tongue. The child doesn't know where the tongue is in the mouth, so because there is no more information. And actually, this was very well described in the 1960s. So this is not new, but it has never been applied to sleep disorder breathing. So that's fairly simple and very important because you can re-educate, and even in adult with severe sleep apnea, there is we did a lot of the pediatric cases in Brazil. There were a lot of study, and in Australia study on adult, and you can cut in half the measure that we use to define severity of abnormal breathing, which is called the apnea-hypopnea index. And Dr. Guilleminault and her colleague showed that with not a very long duration, but within 3 months of daily re-education of this muscle, you can really reduce that index. So it's very important, but the goal, you see, is to avoid to have people, adult, with already a lot of changes, complication, and abnormal breathing. So we have to start when that developed.
Start young.
Exactly.
The younger you start, the better.
The more, when you recognize the abnormality, treat it because you prevent.
What about breathing re-education, like Buteco breathing?
Well, when you do this re-education, you not only teach the child to breathe through the nose, to slow down, but also it goes to the posture. Because if you if you breathe poorly, you are going to have your neck going forward because you open more your upper airway like that, and you have to teach a child to have a normal posture. Yes. It's a whole body re-education because breathing has a big impact on everything else.
So they kind of go together, breathing re-education, the myofunctional therapy. What about expansion of the arches? If the child didn't keep their tongue to the roof of their mouth and expand their arch that way when it was pliable, and so then later on, how important is expansion of the arch so that the structure as well as the function are good?
Well, one other thing, which if you don't have normal function, you don't grow the bone, and what ends is that you have a very narrow and high hard palate, and which is a sign that you have a problem. So, and it's related to the abnormal position of the tongue, because the tongue should be high and should act on that specific cartilage here, intermaxillary cartilage, and that's what makes your face grow. So yes, we can take over what had not happened before, and that's where we do the expansion. And the expanders work very well for the maxilla. The problem is that we don't have a cartilage on the mandible. We have the condyle, and we can reposition a bit the teeth by making them straighter, which give a little more space. And we try to, when you expand, you give more room for the lower jaw to have a clockwise rotation. And which is very important because it means that you go forward.
And if that goes forward, you have more room for the airway back here.
Exactly. And but it's sometimes difficult when you arrive and you have an important retroposition of the mandible. And that's where we have limitation today. We can expand very well. We can try to do what are called bimaxillary expansion. We gain very well on the maxilla, but not very much on the mandible. So we do all this re-education, but there are some children where we are going to arrive a bit too late, and we are not going to gain enough. So these are the children that are going to have some surgical approach. And unfortunately, the surgical approach are not necessarily orthodontic surgery, because it's different. It's really for the airway. So it's a new field of research. We can try to do surgically assisted rapid maxillary expansion after 15 years of age. We can do also a section in the middle and put an expander to do upper and lower expansion. We usually, at least my philosophy is, we always wait till the child has finished growth before we cut. Because we learned that once you cut, it's much harder to have an impact on growth of the child.
So expand as you can before you have to cut.
Correct, and we usually don't do that before 16 years of age.
Okay. Can I ask you just a couple other things?
Go ahead.
So in the treatment of sleep disordered breathing in someone age 16 or above, you'd start with myofunctional therapy and breathing re-education before you would do a CPAP?
And where does
a mandibular
we do an assessment.
Okay.
You see, and sleep disorder breathing can be very detrimental to learning, cognition, and memory. And
As
school,
well as heart attacks and everything.
well, not in a 16-year-old, but the young people, it's the brain, and it's the prefrontal lobe, and it's cognition, attention, hyperactivity, pseudo ADHD, all these things.
Okay.
And you have to see how important is it also for the school, for learning. So we are going to sometime have to put a CPAP because of the problem at school to take care of the acute learning problem.
Right.
And we try to use the mask, which are purely nasal, and maybe pillows, the one that push the least on the face, because
that can alter the face as well.
It does, and it has been very well demonstrated. So, and we know that 1 year of facial CPAP mask already have a impact on the lower jaw, and
which creates worse.
Yes, it's
worse airway.
Yes,
so it's a cycle.
Yes, but we have some time to do that. In the same time, we are going to look at what can we do. Right. We always look: is there a short frenulum? Are they congenitally missing teeth, which is a problem? All these things we do, we try then to address the problem. Yes. And then we are going to systematically do muscle reeducation and nasal reeducation. But we may have to do more. And that's where the question of surgical intervention come up, and which surgical intervention. Right. When you have a child who had a problem untreated since very early in life, you may have a much harder problem with only reeducation to get back to normal, and you will go much faster with some surgical act. Okay. So there is a decision made of how bad is the problem, and then you decide what type of surgical approach you are going to use. Okay. And you will always use a surgical approach with muscle reeducation, always. And you have to tell the individual that it's a daily work.
With the muscle reeducation.
Yeah, and minimum 6 months.
Minimum 6 months.
Yeah.
What about orthodontics, where they take teeth out and?
Well, my view is we are very, very against that. I mentioned that oligodontia, which means lacking the permanent teeth, is a big problem because you don't protrude. You have a bone retraction. Yes. Okay, so if you pull out permanent teeth, you are going to have a problem, and the earlier you pull the permanent teeth, you are going to have more and more problem. And one of the issues is, why do you pull these teeth? And usually it's because you have a small oral cavity, and the orthodontist very often will say, well, I want to give you a nice smile. Right. And what they do, they pull the teeth, and there is a gap, so they put a headgear which is going to push the upper teeth backward and try to align them with the lower teeth, which is completely irrational. Right. Because you make the oral cavity and the support of that collapsible tube smaller. Right. So you should avoid these things as much as you can, and you can perfectly use expander, and now we can even do surgical assisted expansion, There is no excuse to pull teeth which are going to have a very negative impact on your upper airway.
What about mandibular advancement dental devices for sleep apnea?
Okay. Dental devices have been recommended for adults, okay? And they are dental devices, which mean that they are going to have an impact on your teeth,
yes,
okay? And that impact is always going to be detrimental,
okay,
because you are going to move the teeth in the direction where you apply forces. That's what you do with braces. That's what you do with that orthodontists know that very, very well. So one of the first problem of the dental device is that we want to move the bone, and we use the teeth as the way to move the bone. And that's not very good because we are going to move the teeth, but we are not going to move the bone that much. We move the bone much more with muscle reeducation because the interaction muscle-bone. The second thing is what we are going to see. Most of the dental device anchor on the upper teeth, right, and protrude the lower teeth. Right. And you have had improvement with some monoblock, with now the biblock and different type. But when you look at the long-term effect, and it varies depending on the individual, some may have a bite problem within 2 or 3 years. Some will have a bite problem within 7, 8 years. But at the end, you always are going to have a bite problem, right, because you act on the teeth. Right. So the rationale is the following. We have adults and they have a sleep apnea. They don't want to use CPAP, and they have risk of other complication, comorbidity. Right. Right. So to have an abnormal bite may be a cheap price to avoid the complication, the comorbidities. Well, we have to really think about that. Is there anything else? Did we try to do the muscle? And in our community, I would say 1 in 100 orthodontists think about muscle reeducation, yeah, and they all will think about dental device because that's a publicity. Mm-hmm. Publicity is not necessarily what should lead medical treatment.
Right, no, for sure. So the oral sleep appliances that protrude the jaw, they're going to have an impact on the bite. And is there an indication when you would use that as opposed to, or would you never?
You know, it's again an issue of what are the risks of comorbidity, okay, and what can the patient, on the top of that, you know, the older the patient, the greater your risks are going to be on your teeth also. You know, if you start using a dental device at 65, you may have a problem because the gum, everything may not be in great shape, and you may lose a teeth. So usually the recommendation is currently not to have too severe patient and middle age. Okay. But you have to realize that these patients, you have to tell them that at one point, if they do nothing else, they are not going to be able to use their dental device because their bite is going to change too much.
Is there anything else you'd like to say before we close?
No, I would say there are a lot of always new approaches which are publicized, including for children, including right now, the big thing is the BioBlock, and does that work? You know, there have been all these appliances which were used in Germany, for example, to make the jaw grow, and we demonstrated that no, they had the normal growth, but they didn't grow because they had that appliance. So I believe that before we say this is really a good new approach, we have to demonstrate with real information, with double-blind study, and following sufficiently long the children to know the pro and the con. And too often this is not done.
Okay.
So they are too often testimonial. I put that appliance, and the child and the family came back and said that it was wonderful. That's not a scientific demonstration. We need to have the information. How much do we help? How long does it last? What are the complications? How long we followed? All these things have, and that's too often not done.
Okay. Well, Dr. Guilleminault, thank you so much for being with us.
You are very welcome.